I'm Savati Shah. I'm director of the Precision Genomics Collaboratory here at Duke, and it's my great pleasure today to introduce Dr. Rasheed Gbadegesin, not only an incredible colleague of mine at the Duke Molecular Physiology Institute, but also a good friend. So Rasheed, thank you so much for being with us today.
Yeah, thank you so much, Vati, for giving me the opportunity to interview with you. I did not know that you've acquired a new degree in journalism.
I'm multi-talented, Rasheed. Okay. Rasheed, I think the work that you do in your lab is truly impactful in the translational space. You do basic science, but it's basic science with the lens towards improving the care of patients. Can you tell us a little bit about your incredible research program?
Thank you so much, Svati, for that question. So I will just start by saying that our research focuses on using genomics and other omics tools to understand the pathogenesis of nephrotic syndrome and other glomerular diseases. We focus especially on a morphologic type of nephrotic syndrome called focal and segmental glomerulosclerosis. If you talk to nephrologists practicing in the US, they will let you know that FSGS, that's the abbreviation for focal segmental glomerulosclerosis, disproportionately affects people of African ancestry, and it is a leading cause of end-stage kidney failure in the USA. So using our genomics and multiomics approach, we and our collaborators have identified at least 10 genetic causes and genetic risk factors for nephrotic syndrome in the last 15 years. Most of these loci and genes are currently the subjects of studies to identify novel pathways that may lead to new therapeutic targets. And this is actually what is exciting about it. You are starting from the patient, you're collecting the sample, taking the sample to the lab, you interrogate the sample, you identify genetic causes, and then once you identify the genetic causes, you then say, okay, how does this cause disease? And that's actually what leads to a new therapy. And I will illustrate that by actually paying tribute to my late mentor, Dr. Michelle Nguyen, who started this program many years ago. Dr. Nguyen identified mutations in TRPC6 as a cause of autosomal dominant FSGS more than 15 years ago. It is interesting to note that compounds targeting TRPC6 are now in phase 2 and 3 clinical trials for the treatment of both familial and the more common idiopathic FSGS. If you talk to people in the biopharmaceutical industry, they will tell you that this is actually a phenomenon turnaround, between discovery and then talking about clinical trials. So that's actually less than 20 to 25 years. In talking to people in the industry, it takes a lot longer than that. So to Michelle Nguyen, talk about lasting and enduring legacy.
Rasheed, Dr. Nguyen was such an incredible woman, and it was a huge loss to the scientific community, as well as I know to you and I personally, that she is no longer with us. So thank you for remembering her and continuing her legacy and her passion for what a physician scientist can be and how research can really impact what happens to patients.
Thank you very much, Vati.
Rasheed, on sort of that note, again, you and Dr. Nguyen, both excellent examples of physician scientists. Can you talk a little bit about how patients inform what you do in research and vice versa, how your research then informs how you take care of patients?
Okay, excellent question. The way in which I will answer that is just to say that you are asking me why myself and Dr. Nguyen during our lifetime are obsessed with basic and translational research using different genomic tools. The simple answer is that personally, I like the idea of seeing patients and trying to figure out why they have a specific phenotype. Why do they have this disease manifestation? And I thought that using forward and reverse genetics and genomics tools are very powerful to actually understand this, and because you are starting from the patient from materials that you got from the patient. So the other thing is, in the early days when I used to pipette every day, I must say that I don't pipette every day now, but when I used to pipette every day, what used to keep me going in those early days is my ability to put a face to the test tubes that I'm working on, and having it at the back of my mind that I will have an answer at some point, and that the answer may impact in a positive way millions of children and adults living with chronic kidney disease. So it's actually a good place to be in. You are seeing patients, you're collecting samples from them, you're interrogating the samples in the lab, and you are making discoveries. I can't think of a better job.
Rasheed, that statement was so impactful. I see the patient on the test tube. It's so important, right? All of us who are doing research, even if we're not physician scientists, to remember that this is about patients and people. So thank you for that wonderful comment. Rasheed, you wear a lot of hats. Yes. You're an associate dean for physician scientist development.
Yes.
And also are training physician scientists and non-physician scientists in your own lab. True commitment to diversity. Can you talk a little bit about what you see needs to be done to train the next generation of investigators in the genomic science?
Okay, yeah. Okay, so thank you very much. So that's a very important question. So like we heard from Dr. Eric Green, Director of NAGRI some weeks ago, we should start very early. We should increase genomics literacy, as he said during that talk. There's a need for continuing education for our established investigators and senior clinicians, okay? So I believe that you can still teach an old dog a new trick, okay? So I think we shouldn't say that, oh, you know, they're done, you cannot teach them new things. That's actually where we need to start from. So there's a need for continuing education for our established investigators and senior clinicians. For the trainees, I will actually advocate implementation of what I would describe as Genomics 101 in the medical school, during residency and fellowship across board. So just to illustrate this, myself and other international collaborators, we are already putting together framework for engaging the American Board of Medical Specialties and other boards of medical specialties around the world to actually include genomics, fundamentals of genomics in the training of the next generation of nephrologists. So this is very important because whether we like it or not, that's the future. That's the future of medicine. In fact, what I tell people is that for genomics, the future is actually now, because every clinic, all my clinics, every week, there is always one result or another that my colleagues and my trainees will bring to me and say, oh, you know, we got this result, and what does it mean? And then I'll sit down with them and then explain to them that this is what this is all about. Now, that is not sustainable, you know, having one person and, you know, 10 people coming to you to ask for this all the time, when that's actually not your, you know, primary job. So whether we like it or not, we have to start the training. In fact, not from medical school, actually undergraduate, and even from high school, and actually get to what we call genomics literacy, because whether you like it or not, a time will come when you will be seeing a patient in the clinic, after you've taken the history, the patient will say, oh, by the way, this is my genomics profile.
I love it, Rasheed. You're thinking all the way from really early, you know, in high school And not ignoring the established investigators and physicians who still, can learn and understand what genomic medicine means, even if not the ones directly practicing genomic medicine. Eric Green, when he spoke, as you referred to, mentioned the 10 bold predictions, right, for the future of genomic medicine. And one of the bold predictions was that elementary school children will have genetics at their hands and be using it, on a regular basis. So,
and I totally agree with that. So just to illustrate that, when my daughter was in elementary school, I was actually asked to give a talk to third graders on renal physiology. So I think the next thing is we're actually going to be going to the class on a regular basis to give talks on genomic medicine generally.
I love it.
Yeah.
You outlined one obstacle with what is the current future of practicing genomic medicine and translating discovery into patient care, which is educating clinicians and investigators. Can you kind of talk a little bit about what other things do we need to overcome to truly have a translation of important genomic discoveries into patient care?
Okay, fantastic. That's a great question. So it is amazing that we started from $1 billion genome. And as at the time when we listened to Dr. Green a couple of weeks ago, we're actually down to about 1,000 genomes, $1,000 genomes. So we need to have a pipeline that will give us the ability to actually maximize the benefit that we can get from this enormous amount of data that we are accumulating. The other important thing is that whether we like it or not, there is an imbalance in what is available in the genomics world, for example, and this will actually impact the way in which we interpret our results. So let me give you an example. So I'm currently part of a group that is working on genomics of chronic kidney disease in Africa. And it is quite interesting that when we try to pull out studies to actually look at genomic studies that have been done in Africa, like every other thing, Africa is behind. So we have to address that disparity. We have to address equity in genomic research and the way in which we are accumulating genomic data. Putting it this way, actually we need to do that if we want to develop the ability to be able to interpret our findings correctly. So somebody can make a discovery and say that, oh, I found this variant. I actually think that this variant is very, very rare and is likely going to cause disease, okay? It turned out that this variant was actually discovered in somebody of African ancestry, okay? The controls that is available to that person to really determine that that variant is really rare isn't that much. So the person may actually be reporting a false positive result. So we have to move towards generating millions of genomic data that we cover, different populations across the world. And then that way, when we get our results, we can interpret our results confidently, and that's actually going to maximize the benefit that we are going to get from all the cutting edge technology that we're developing every day.
Such an important point, Rasheed. I think having diverse ancestries in the studies that we do, genetics has a huge potential for improving health disparities, as you have shown in your own work, but also historically and continues to have potential for actually exacerbating health disparities. So it's a really excellent point.
Yeah.
Rasheed, it was such a pleasure speaking with you today. Thank you so much for your time and your insights about genomic medicine. Really fantastic work.
Yeah, thank you so much, Svati, for having me, and thanks for all the excellent work that you are doing. We are all looking, to you that we are going to get there ultimately. Thank you.
Thank you.
Yeah.